Let me first paint a picture. A person wakes up every day feeling like they're sitting on a burning nail. What the hell is actually going on?
I'm laparoscopist and urologist. This is my main specialty. The doctors want to see to believe. And many times when we do the exam, all the exam looks normal. But the patients are not crazy. We have more bad doctors than crazy patients probably. And
Just imagine that I have no idea about anatomical language and physiology. How would you explain where this is located on the body?
the problem is very simple. When you have an injury of the nerve, you have two mechanisms. It can be squeezed or it can be stretched. The patients can be really confused. They arrive in the consultation with the main symptoms. They arrive, they say, I have, I don't know, pain. Usually they have, but they don't associate with the same issue.
If you go to one doctor and get a diagnosis, and then you go to a second doctor to get whatever diagnosis, it's only a 12% chance that you will get the same diagnosis from two different doctors. Let me first paint a picture. A person wakes up every day feeling like they're sitting on a burning nail. They can't sit, they can't work properly, intimacy is painful, and every doctor tells them, you're fine, it's just probably stress or another form of misdiagnosis. So, what the hell is actually going on? So, doctor, just tell the audience who you are and what you do.
Well, I'm laparoscopist and urologist. This is my main specialty. And a little bit by accident, I became also a specialist for the treatment of the perineal and perineal pain because one of the surgery is feasible laparoscopically. Is the reason why I was involved in that field. And also, as everybody, we have many patients in our consultation, in our daily activity. And it's very easy to miss the diagnosis. It's very easy to miss the diagnosis because the doctors want to see to believe. And many times when we do the exam, all the exam looks normal. But the patients are not crazy. We have more bad doctors than crazy patients probably. And I'm sure that when the patients arrive with a complaint, he has something behind. That's the first thing that we have to put in our mind, also when we don't understand what's happened. But with the experience, finally, I realized that all these patients who suffer from pain in the perineum, they have a common profile. And when I have a discussion with my colleague who assists to my consultation, they are always surprised. And usually they told me, but they explain the same story. I say, yes, it's because it's the same disease with different symptoms, but it's the same problem. Because of course we have the problem of the pain, who is very well known, but probably the pain is just the summit of the iceberg. Because this pathology is much more wide than just the pain. More or less, all the functional issue that we have in the perineum can be potentially related with the perineal issue.
And just imagine that I have no idea about anatomical language and physiology. How would you explain where this is located on the body, just with layman terms?
And finally, basically, the problem is very simple. When you have an injury of the nerve, you have two mechanisms. It can be squeezed or it can be stretched. This makes basically the true mechanism. And also, when you are blocked or when you are compressed, it's always between two structures. And the most common is not in the Alcock canal because it's a pathology described as the Alcock syndrome canal, but it's not the most common problem. The most common problem is proximally located on the way of the nerve. Then if you see here is the model, and we can see this is the buttock here. The main muscle is removed, and behind we found one muscle with the key of the problem is the piriformis muscle. When this muscle became overcontract, it squeezed the pudendal nerve who is running here between the piriformis muscle and the sciatic ligament. And in majority of the case, the point of compression is at this level. And what is interesting is at this level, you have other nerves. You have also the sciatic nerve, and you have another nerve who is not represented on the model, with the posterior femoral nerve. And it's really common that the patients, when they have a compression at this level, they can have also some symptoms in the sciatic nerve or the posterior femoral nerve. And this is the most common point of compression. Behind that, the nerve is continuing to running, and it can enter under the sciatic spine, just at this level, before to go in the alcohol canal itself. But the alcohol canal is maybe 15% of the compression. Majority is more proximal. And this is very interesting because, of course, we have on one side the fibrosis of the ligament, and on the other side, you have a hypertonicity of the piriformis muscle. And this is the key of the conservative treatment because the fibrosis is something that we cannot change. But the tonicity of the piriformis muscle can be a target of a conservative treatment as a first intent.
And how do the patients explain their symptoms?
Usually the symptoms of the patients can be really confused. They arrive in the consultation with the main symptoms. They arrive, they say, I have, I don't know, pain. But it's very important to discuss with them about all the peripheral symptoms that usually they have, but they don't associate with the same issue. I give you an example. If a patient has a premature ejaculation, these small symptoms is very highly specific to the pudendal nerve entrapment. And when somebody told me I suffer from premature ejaculation, I'm pretty sure that it's a pudendal nerve issue, independently of the main of the symptoms who justify the consultation. And it's very important when we discuss with them to check all the systems who can be in trouble. Then we have a group of questions about the anerectile function, sexual function, urinary function, and also we need to have a picture about eventual postural issue who can be the origin of the compression of the contraction of the.
So premature ejaculation, how often is it due to an issue with the nerve?
This is really common. This is very common. And what is interesting is typically is the symptoms associated with the psychological issue for the doctors, because it's like that we teach, that we receive the explanation
Exactly.
when we are in the university. The professor that told us, this is a psychological issue. But it's not true because I operate many patients with these symptoms and these symptoms disappear. What is interesting is also we have an equivalent in the woman is the arousal syndrome. The arousal syndrome is the sensation of the woman that they go spontaneously to an orgasm. It's very rare to go really to an orgasm. I have a patient who had that issue, but usually it's the sensation that they will go to the orgasm. It's exactly the same. It's the hypersensitivity of the fibers who control the orgasm in the pudendal nerve who are overexcited due to the compression.
That's super interesting. Yeah, because most of these issues are mostly described with some form of psychological treatment, or they just blame it on stress because they don't know the actual issue behind it.
Yes, it's usually like that. We always say, you have something who is changing in your life. But I have a patient like that. He arrived with premature ejaculation and I ask him, did you change your wife? Say, no. Did you change your job? No. Did you change your dog or your car? He say, no, I changed nothing, but I don't know what's happened. I have this problem. And finally, when
Yeah,
I
and
discussed with him, he had this problem and after the surgery, the problem disappeared.
and then if you also come up in age, like you're coming up in your 40s, they can just say it's age related.
Many problem is always age related. When you think
Yeah.
about, I give you another example for the erectile dysfunction. We say, yes, you are 55, it's your age. But what it means when you say it's your age who is responsible for erectile dysfunction, what we do usually, we say, okay, when you have erectile dysfunction, you have to go to have a checkup for the heart to be sure that you don't have a coronary disease, because it can be, of course, an arteriosclerosis who give an obstruction of the pudendal artery can explain the erectile dysfunction. But in 91% of the case, the patient had a normal evaluation of the coronaries. But you have to know that the coronary diameters is the same size that the pudendal arteries. It means that if you don't have arteriosclerosis in your heart, what you should do have arteriosclerosis in the pudendal artery. And in my experience, I have some patients who refuse to take pills. I remember a case, the patients refused to take pills because his wife told him that it was not a bio sex, it was just like a jukebox. You put the pills inside the machine and then you have two things. Finally, this patient had a normal cardiac evaluation, and yet some other symptoms can be suspicious to be a pudendal nerve compression. And he decided to go for a surgery. And after the surgery, he recovered completely his erection. Then I think that probably The problem of the erection in majority of the patient is extra arterial compression and is not atherosclerosis in the artery. It's not the only solution, the only reason. Of course, when you become older, you have a high risk to have other disease associated who can be also the origin of the problem, or you can be under treatment who also increase the risk of erectile dysfunction. But in the significant numbers of cases, probably the problem is extra arterial compression.
I want to ask you about misdiagnosing this issue because I read Tony Robbins' book, Life Force. And in that book, he says that if you go to one doctor and get a diagnosis, and then you go to a second doctor to get whatever diagnosis, with whatever it might be, it's only a 12% chance that you will get the same diagnosis from two different doctors.
Yeah, that's completely true.
So with this in mind, I think this book came out 2016 or 18. Whatever I do, I started studying naturopathic medicine when I was in my 20s. Whatever I've suffered from or felt, I always get not only a second opinion, a third, a fourth, a fifth opinion about what is going on, because I want to see my body, my health, or the issue that I'm experiencing from a more holistic view.
Yes, I say always, the doctors are never so dangerous when they are in group. You are completely right. This is
And
the
can you
problem of the
explain
patients,
that?
particularly when you can not see something, because it's finally, if you don't have an exam to confirm the diagnosis, it's only the personal experience of the surgeon who can give you an idea about what you can have, what is the real origin of the diagnosis. And particularly in the pudendal or the neurological pain, you have a very big problem is when you have an anesthesia, the neurological pain disappears for 7 days. Then it's completely confusing also in the head of the patient, of the surgeon, because they do the surgery, the patient feel better for 1 week and they conclude it was a good diagnosis. But in fact, it's not true. In the neurological pain, just the general anesthesia is enough to suppress the pain transitory. I have a woman who was from US. During years, she had general anesthesia every 10 days. It was the only manner for her to survive to the pain. Then she had just general anesthesia and nothing more. And like that, the pain was under control for 1 week, more or less. Then it's very difficult because sometimes we have a misunderstanding of the effect of what we do. And it's very important to have very close follow-up with the patient. And it's very important to be aware about the symptoms reported by the patients. It's like that, only in that manner that we can understand really this pathology. For example, I can give you, because my experience is based only on the experience and the return that I have, the feedback that I have from my patients. I remember that when I start to release the pudendal nerve, we release also the pudendal artery, but it was not the goal of that surgery. And it's my patients who are coming back and they say, "Oh, doctor, thanks a lot. You put a few centimeters more on my penis. When I'm in the shower in my sport club, I feel not so shy because my penis looks bigger." At the beginning, I was a bit surprised, but it makes sense because we release the pudendal nerve, but we release also the pudendal artery. And after that, I remember all the patients in the past who are coming in my consultation with that complaint. They say, "My penis is shorter." I say, "Okay, it's not a big issue if it's just in the flaccid position, we can do nothing." But they were not crazy. They have exactly the same problem and the same observation that my patients who feel better after the surgery. And it's like that we can continue to build an experience and to give the explanation to the patients. After, the difficulty is to join the observation and the feedback and to build a logical relations between the different events. But I think that actually after, I don't know how many patients, maybe 600-700 patients operate, we can say that we have a good knowledge and understanding of this pathology. We can never be sure. That's real. I say always in medicine, we believe a lot of things, but we are sure of nothing. This is maybe also the reality. But when we see the efficiency of the treatment proposed, we are probably in the truth for at least 90% of the explanation that we give.
Yeah, I think your humble approach there also gives you more wiggle room to actually explore what actually is going on, and instead of just saying that I know this and being blind for what might actually be the issue here. And I want to circle back to the symptoms. We said premature ejaculation, arousal dysfunction, erectile dysfunction, but I've also heard that people can have like massive pain in that area.
Yes.
Not only, we're not talking about the hips, we're talking about like behind the balls, for a lack of better anatomical
Yeah, yeah.
vocabulary here.
The pain is probably the most common symptoms because this pathology at the beginning was the pudendal neuralgia. That it means the pain of the pudendal nerve. Then patients arrive, majority of them, for pain. The problem with the pain, in fact, is the pain is not specific to the nerve. You can have a pain from the nerve, from the articulation, from the tendinous, and from the muscles itself. Then when somebody told you, I have pain, it's not a diagnosis. It's very difficult to define exactly the origin of the problem. The only thing which is interesting in the pudendal nerve is the pudendal nerve innervates all the perineum, from the tip of the coccyx, more or less, going through the anus, the scrotum, the vulva in the woman, the urethra, the clitoris, and the superior part of the pubis. Then all this territory can be painful due to pudendal nerve entrapment. The problem again is this surface of the perineum is overlapped with other nerves. Then sometimes when you have a burning sensation there, you don't know which nerve is involved in the symptoms, except if you have three spots. If you have pain in the gland of the penis, in the clitoris, in the urethra, or the entrance of the vagina, these four places are innervated only by the pudendal nerve. Then if somebody has symptoms in the clitoris or the gland of the penis, it's 100% sure to be a pudendal nerve issue. And this is very important, is the location of this of the pain when you have a very specific territory related with the pudendal nerve. But the problem of the pain is also, and it's the reason why it's confusing in the treatment of the patient, is the typical pain in the seated position. Many patients have a pain in the seated position, and the origin is a muscles contracture. And when you have a muscles contracture of the piriformis muscle, you have this muscle can be painful when you're sit, and it can push on the nerve, and after you have the burning in the perineum. Is the reason why actually we propose two different types of surgery to decompress the nerve. Because the first surgery originally was to cut the sciatic ligament, to turn around the sciatic spine, and to open the alco canal. That it means that we perform an anterior located decompression of the nerve. But what I observe is some of my patients feel better because the burning sensation disappeared, but they were still unable to be seated. And in fact, the key of this problem was coming from one of my patients, because the burning sensation disappeared, but it was still impossible for him to be seated. And it was a big issue because for professional purpose, he has to be seated all the day. Then finally, he contacted me and he told me, yeah, I see somebody who removed the piriformis muscle, and it seems to be maybe the origin of my problem. And I just look on the internet and I did some research to understand the problem. And I told him, yes, it's possible that's the origin of your problem, but it's maybe possible also to avoid to open your buttock in two pieces to remove it. We can maybe do a minimal invasive surgery just to release the tension in your piriformis muscle. And it's like that we start to propose a second surgery. And instead to cut anteriorly, we go posteriorly through the buttock, and we cut the piriformis muscle with the minimal invasive access. And like that, we have the possibility to help a part of the patient who had a partial failure of the first surgery. I say always the most interesting patients group is not the patients who goes well, is the patient who goes worse, who goes bad, because finally it's for this subgroup of patients that we miss something. And it's for them that we have to continue to make some research to try to improve your knowledge and or understanding. It's very important. We cannot save all the patients, that's for sure, and we have to be humble about that point. But we can help a majority of them.
A lot of people listening now are going to wonder, Is it usually like one big trauma, like a fall, or is it more slowly sneaky buildup from things like cycling, gym, or sitting too much? Are we too sedentary? What is the issue for having these?
In fact, the pain is not just one single event. Usually, it's an addition of risk factor and trigger effect finish to give the symptoms. But for the trauma, for example, because it's a classical story, is the patients who fall on the coccyx, and they explain at the beginning, I had a pain in my coccyx, and after 1 week, I start to develop burning sensation in my perineum. And this is typically a myofascial issue. When you have a painful area in your body, all the muscles are surrounding the painful area will become contract to try to stabilize the pain. It's like when you have a shoulder luxation. If you go in the same day to the emergency, we can replace your shoulder in place very easily. If you arrive 24 hours later, all the muscles around are so tight that it's impossible to reduce it. We need to go in the OR for that to sleep you to replace your shoulder in place. It's exactly the same. You have the trauma, all the muscles became contract. One of the muscles is the piriformis muscle in this area. And then after that, you develop the pressure of the nerves and you develop the pedial nerve problem. This is what's happened when you have an acute event. And one important message is for the patients who develop the problem after surgery. I have a significant numbers of patients who arrive in my consultation that told me I was operated and after it became the hell. And this is just for one reason. All these patients were placed in lithotomy position. It means like when you are in the consultation with the gynecologist with the legs lift up, when you operate in this position, you can decompensate the pedial nerve issues. I know many cases with that story. And the common point of all these patients who were operated, the trigger point was the position on the table. Not with the medical fault. It was just because they have a limit situation and it was just the drop in excess and suddenly you develop the symptoms. This is one part, is an acute event who decompensate the situation. But you have many patients also who had a postural issue. When your bone pelvis is not well balanced, it's lightly anteriorly tilt, you develop a myofascial syndrome. Then many muscles in your body became contract. It starts in your thigh, you have a contraction in your buttock of the piriformis, but you can have also contraction from the paravertebral muscle all along the vertebral column, just because your bone pelvis is anteriorly tilt. When you think about the bone pelvis can be tilted if you have one leg shorter than the other one. Then significant numbers of patients can burn with one leg shorter than the other one, and they start to develop the symptoms when they became young adults. I have few cases of pediatric case. They start the symptoms around 7, 9 years old because they have a major issue, postural issue, and they start the symptoms very, very earlier. Then you have more or less two groups of patients. For me, you have the patients who develop the symptoms when they arrive around 20 years old, and you have another group of patients who are older than 35 years when they start to have to develop the symptoms. And the first group probably is because you're born with the problem, and the second group is because you have a small accident of the life, like a knee trauma when you ski or something like that, and then you develop a imbalance of bone pelvis in the second time.
I also heard that people can experience pain often like a spike after sex or an orgasm. What is going on there?
Yes, it's a very specific and classical from the patients is the sexual activity will worsen the symptoms. That's really common. It's a part of the specificity of the rhythm of the pain because the patients classically, they have no pain during the night. That's an interesting point. And it's also the explanation why some of them finish in the psychiatric consultation because they have a lot of pain during the day and nothing during the night. Then the doctors conclude he's crazy, but it's not crazy. It's completely logical. Why? Because the origin is the tension of the piriformis muscle. And when the muscle is contracted, it's squeezing the nerve. But when you sleep, all the muscle became contract. Then the symptoms can disappear during the night. This is one issue. The second is probably the sexual activity is one of the strongest stimulation for the pudendal nerve. The women say always, when I have sex the day after is bad. If I have an orgasm, it's much worse the day after. This is also what I say to my patient. if you are able to have a sex activity without a worsening of the symptoms, you are cured. That's for sure. But many things can also influence the symptoms. Huh? For example, you have some patients who feel better during the night with a cushion between the knee. And somebody who sleep with a cushion between the knee, it's just because when you do an external rotation of your hip, you reduce the tension in the piriformis muscle. Then it's more comfortable for them. You have also the patients who say, I like to walk because when I walk, my pain disappears or I feel much better. It's only because when you walk, again, the muscle became warmer and smoother and the pressure on the nerve disappear also is improved. The problem is when you walk, you feel better, but if you walk too much, the day after you have lactic acid in the muscle, they became contract, and then you have a worsening of the symptoms the day after the physical activity.
So my question is, when we were speaking about like muscle and the muscle being tense, can't you just stretch and have the issue disappear?
Yes. And we don't
Yes, you
operate all
can.
the yes, you can. We don't operate all the patients, and it's the reason why I told you it's important to understand the mechanism who finish with the pudendal nerve compression, because it explains also where we can have a target of for the treatment. And of course, the only thing that we can do is not to change the fibrosis of the ligament, is to reduce the tension in the piriformis muscle. For that, finally, what we do is usually 4 things. The first, we have to control the postural issue. Then we send the patient to the chiropodist for postural evaluation, and we correct the unbalanced bone pelvis with insole in the shoes if it's possible. This is the first. The second, we do stretching exercise of the piriformis muscle. It's useless to target the muscle of the perineum because the muscles of the perineum are contract, but it's because they are innervated by the pudendal nerve. Then when we squeeze the pudendal nerve, it sends a lot of false information to the muscles who became overtoned in the perineum, okay? But it's just a consequence, it's not the origin. The origin is the piriformis. Then we do stretching exercise of the piriformis muscle. The third thing that we propose is to use machine gun pistols. It's a small device with the balls who vibrate to provide a deep massage in the superior part of the buttocks. That one can also help to relax the muscles. And the fourth one is a Botox injection inside the piriformis muscle. And it's interesting because we don't inject only Botox. We inject Botox plus local anesthesia, and we can differentiate both effects. The local anesthesia will be efficient directly, but for maximum 1 day. But if the patient told me after the injection, I was able to be seated and it was less painful, we know that he has a muscle issue in all the symptoms that he described. The Botox will be efficient 7 to 10 days after the injection, and it can stay efficient for 6 months. Then I have some patients, instead to be operated, they just repeat 2 or 3 times a year a Botox injection in the piriformis muscle. It can be also a therapeutic approach. Unfortunately, the conservative treatment will cure only 15% of the patient, completely cured, then no symptoms. But it will improve 2/3 of the symptoms, the patients, for more or less 60% of the intensity of the symptoms. After that, it's always a functional issue and a question of personal goal. And some patients are happy with what they have after the conservative treatment. The other one wants more, and in that case, we have to go for surgery.
And are there any major differences between men and women?
Yes, the first thing is to be a woman, as for many other problems, is a risk factor, just because they have also the potential trauma of the deliveries. Then deliveries can be also a classical reason to have a trauma of the perineum and the pudendal nerve. Then it's a risk factor. The other thing is also maybe the hormonal fluctuation who modified also the elasticity of the tissue. And statistically, I have more women than men.
So it's after giving birth they
Yes.
can experience these issues.
Yes.
All right.
And this mechanism in after birth and delivery is not a compression, is mainly a stretching of the nerve. Then the prognosis is a little bit better. The nerves can recover, and it can take 6 months to 2 years to recover completely. But if a woman have this experience for the first delivery, my advice is no more deliveries, but a C-section if they want more kids, because each deliveries will add another trauma, and we have a risk to have an irreversible lesion in the nerve.
So it seems to me I'm not a surgeon, but the pelvis is not exactly an easy place to work. So how do you navigate that area safely? Are you using robotics or advanced technology? How do we go about this?
For the surgery, for all the surgeries, the most important is the experience of the surgeon. That's the key point, because of course you can study the anatomy or what you want, but when you approach in the one angle of direction to approach a structure, it's not the same landmarks that if you go from the other side. Then you have to work with your brain to relocate everything and to find the landmarks. And of course, with the experience, you know better and better the details of the anatomy based on your experience. At the beginning, we need to be very careful just to be sure that we well identify all the structures. But just to give you an example, at the beginning, this surgery was easily 1 hour 30 minutes to free one nerve. Actually, we are more around 30 minutes for the same surgery. Then clearly, the experience is very important. The problem is we work on the very thin structures. Then more or less it's impossible to have, or very difficult to have an exam who can show you exactly the so small structures in the pelvis. Concerning the robotic, I know that some colleague use the robot because it's easy for the surgeon, huh? Because you don't need to manipulate by yourself the instrument. The problem with the robotics is the tactile sensation. Then you have an advantage is the fact that it's more comfortable. You have also the instruments who are angulated, and then you can go in the depth angle, or you can have an easier access in some point of the dissection. But the problem is you need to feel the resistance of the tissue. And only the last generation of robot, they start now with the tactile feedback sensation, but it's still really size. It's not like when you have the instrument in your hand. And for me, I feel more confident with the laparoscopic surgery for the dissection of the small structures. But I know that some of my colleagues, they use the robot for that kind of surgery.
And just clearly, what was the difference between the laparoscopic approach over a traditional open surgery?
No, open surgery, you have to forget it. It's impossible to do it open because it's so deep, so deeply located in the pelvis. It's impossible to do it open when we do anterior decompression. And of course, posterior decompression you can do open, but you have to open the buttock in two pieces to arrive on the piriformis muscle. It's the advantage. It's a minimal invasive surgery. For the anterior decompression, we have just to do 4 small incisions in the belly and put gas in the belly. For the posterior dissection, we have to do just 2 small incisions in the buttock. And it's a minimal invasive surgery. It's also a big advantage because sometimes I have patients with a very bad case. Huh? You have patients very old who have symptoms for 25 years. They have symptoms day and night. Day and night symptoms is a poor prognosis because we never know if the lesions are irreversible or not. But also for these patients, I propose surgery because, okay, I know that maybe instead to have a 80-85% of success, it will drop to 30%. But if it doesn't work, they will have just few small scars in the belly and nothing more. Then it stay reasonable to propose in the bad prognostic case. I think that it stay reasonable to propose a surgery.
What kind of success rate are you seeing with your approach?
We are around 80-85% of success rate. The question is always the same. My patient asks me, can I be cured with this surgery? The question is, what do you mean about to be cured? For me, I say always to them, if you can live and forgot that you have this disease in your daily activity, for me, you are cured. But many patients, when they do something unusual, then they took a bike or they do a more extreme physical activity, the day after, they will feel a bit the symptoms. They say, yes, it's true. I have this problem in the past who is coming back when I do something in excess. And for me, the goal of this surgery is to give back the life to the patients. And this is a drama of these patients with the symptoms that they have. They stop first to have sexual activity, usually. This is the most easy for them. They stop to have sex. But after they cannot travel for a long journey, then they stop to take the flight. After they stop to go to the cinema. And after they stop to go to the restaurant. And finally, what they do, they just live face to the pain. And they just wake up in the morning to work because they have to eat. And sometimes they cannot work anymore. Then the idea of this surgery and this treatment is to give back the life to the patient. I say always this is the goal of the surgery. But we have 85% of success rate. But I know that for the other patients, usually we have to decompress from the other side because it can be usually the explanation why we don't have a complete recovery. Because in fact, for example, when you cut the ligament anteriorly, you do anterior decompression. You open the ankle canal, you cut the ligament, the nerve should be more free, then it moves up and he has more space. But after a few weeks, you have some fibrotic tissue will be reshaped. It's a normal process, the fibrosis. We hope that the fibrotic tissue will be a little bit higher than the original tissue and the nerves will have more space. But if you don't correct the piriformis muscle issue behind and you have a muscle who is still under contraction, it can push on the fibrotic tissue instead to push on the ligament. Then sometimes for this patient, after 6 months, when we see that the symptoms doesn't improve, we decide to do a posterior decompression to improve the decompression of the nerve. Then 15% of my patients will need a second surgery because you have a partial.
Like over 20 years with the interest and curiosity around human health, human longevity, how to cure different like symptoms and diseases that are often lifestyle induced. I never heard about someone like you focusing on this area. So the question is, are you training other surgeons or is this a common practice around surgeons? So, or are you just a unicorn around doctors and people doing this specific procedures, but also having like this knowledge around diagnosing it the correct way? Because I personally know people who have gone to you and got help, and they went everywhere. They told me they've like went to every forums, they went to every doctor, and you were the only one that could just like pinpoint the actual issue and giving them the actual cure.
Nobody is unique. This is one thing. But
we can say that you're specialized.
Yeah. I think that we can say that I'm specialized, of course. In fact, I'm a pioneer in laparoscopic surgery. And at the end of the 90s, I was one of the first in the world who start laparoscopic surgery. For this reason, also, I'm always involved in the training program for the laparoscopic surgery. But when the fellows arrive with me for 3 months, they discover the pudendal nerve problem and all this pathology. And I always told them, you will discover the laparoscopic surgery with me, but also another pathology. And what's happened is many of them, when they return back at home, they start to take care about these patients also. Then training, yes. And I think that is one ethic point for all the doctors and particularly the surgeon. You have to transmit our knowledge and our skill to the youngest generation. That's very important for me. Then during all my professional activity, I really take care about the transmission of the knowledge. Okay. Concerning the technique of the surgery, the laparoscopic surgery is easy to do for a laparoscopic surgeon. And I know that because I have a YouTube channel with a lot of full-length videos with a comment to be the most didactic as possible. And I know that some of my colleagues, they start that surgery just after watching my videos, then just using the explanation, the tips and tricks and the pitfalls, they were able to start directly. But the surgery is medicine before and medicine after. During the surgery is the stupid things that we do with your fingers. But the most important is the knowledge of the symptoms of the patients, the knowledge of what will happen after the surgery, because it's very important to continue to support the patient after the surgery. Concerning the second surgery, the piriformis muscle is one procedure that I have developed by myself. Then I start from the classical opening wrist removal of the piriformis muscle. And after I move to develop a minimal invasive procedure to propose a surgery for that issue. Then this surgery is highly specific. In my knowledge, until now, I'm the only one in the world who proposed this approach to control the piriformis muscle syndrome.
I'm thinking about if I myself would experience some issue in my pelvic or any of the other symptoms we've been discussing, what would be the first step in our journey together if I would specifically contact you? How would my customer journey look like?
Yeah, then the first thing is to contact me on to the website, because of course you cannot take a flight from the other side of the world just for a face-to-face consultation. Also, I don't need usually to examine the patient. The anamnesis, if it's well done, if it's precise, I have the idea. It's very rare that I say, this is, I don't know what you have. I can tell you, yes, it's a classical symptoms of the, like my other patients. Sometimes I send patients for more exam because I have a doubt about the diagnosis. But the most easy for patients coming from abroad is to book an appointment by video, and just with the description of the symptoms and also a few exams that I can propose to do on their side, we can confirm the diagnosis and the lateralization also, because sometimes the problem is to know which nerve is the problem, if it's the left or the right side. After that, we always propose the conservative treatment approach, because we know that we will save some patients without the surgery with this approach. And if it doesn't work, the patient has to decide if he wants to be operated.
And you get people from all over the world, right?
Yes, yeah, because you have patients all around the world, but unfortunately you don't have doctors for that problem all around the world. The farthest patient was from New Zealand. I think it was the farthest.
I was going to ask you that. What was the furthest patient you got from?
Then it was New
Zealand.
Zealand. New Zealand, yes. But I have patients from all the world, from US, North Europe, South Europe, Russia, Middle East. Everywhere people are searching a solution. This is a problem which is really common, because probably 15% of the adult aged more than 35 years has some symptoms related with this issue. Not so acute.
How many
that
percent did you say?
15, 15, 15.
15,
15
have
Then
some form of issue with this.
Yes, not like the big pain and the big problem, but it can be a little bit of premature ejaculation. The erection is so-so. The quality of the orgasm is not very good. Some problem of obstipations, because you can have a spasm of the anus, and it gives obstipation to the patients, for example. Sometimes you discuss with the patient and they told you, yes, I try to go to the toilet 4 or 5 times a day. That's typically a symptom suspicious to be a penile nerve issue. Then you have many patients who have this small problem that they live with that without any big issue, but it's related with the penile nerve problem. When I give a lecture in the Congress about that subject, usually 20% of my colleagues come after to discuss with me, to tell me I should discuss with you because I do not have an issue.
I have an issue.
And that is really common. That's really common.
And I don't know if this is related at all, but does Kegel exercises has anything to do with your work?
And the problem is the misunderstanding about which type of physiotherapy we should do. Because Kegel exercise is to try to reinforce the muscle. But majority of the kids, they don't have a weak muscle. They have the opposite. They have over tonicity of the muscle. It depends, in fact, of the intensity of the compression. When you squeeze lightly on the nerve, you create an exceedant of stimulation. It means that through the sensitive fibers who goes through your brain, it will give you pain. Okay, because you have an exceedant of stimulation. Through the autonomous fibers of the nerve, it will give an exceedant of stimulation who will give you a premature ejaculation. And in the opposite, through the motoric fibers who goes to the muscle, you have an exceedant of stimulation who give a spasm of the muscle. Then the patient has usually a hypertonicity of the perineum. It explains the vaginism of the woman. The vaginism is not a psychological issue. It's a hypertonicity due to the pudendal nerve. But if you continue to squeeze the nerves more, you push more on the nerve, you stop the influx. Then from the pain, it became numb. On the other side, from the hypertonicity of the muscle, it became weak. Then you can have two opposite symptoms with the same mechanism, dependingly of the intensity. You can have a urinary retention, and you can have also urinary incontinence, dependingly of the intensity. But the majority of the patient is the first, fortunately, The first part of the problem is hypertonicity. And in that kind of situation, for me, the Kegel exercise is not really helpful because you want to increase the tonicity of the muscle. I say, okay, well, but we do feedback, then you learn also how to relax the muscles. The problem is you try to relax the muscle, but you don't have a good connection between your brain who send the information, relax the muscles, and the muscle itself. The muscle is overtoned because the nerve is blocked, in fact. And it's not so helpful. Of course, you can do also a massage inside the vagina or inside through the anus to try to relax the muscle. That it can give an improvement of for the comfort, because when you have the perineum with always under tension, it can be uncomfortable or painful. But when you do the massage, you relax the muscles. But when you just go outside the house of the specialist, the stimulations along the nerve is coming back, and then the muscles became over contract again after 20 minutes. Then I say always, yes, if you do that, you have to be married with the physiotherapist because you will need it all your life. Then for me, the most important is to target the muscle with the origin of the compression and not the consequence of the.
Yeah, because right there you answered another question that I had, that if you could solve some of the issues with intimate massages in the anus and through the vagina, but also for men, because I have a couple of friends in the tantric communities that perform these type of massages just to release. They call it like de-armoring massages.
Yes.
To like
it
get rid of the
release
armor around the anus and the lower parts.
It give an improvement of the symptoms, but by definition it will be transitory because you don't target the origin of the problem. That's
so it's temporary relief.
Yeah, it's completely temporary. It can be more comfortable. I say always, if it helps you, do it, but don't hope that it will be a long-term solution of the problem.
Because you mentioned that you have your brain sending the signals to the muscle to contract or to get loose. And I've tried the massage pistol that you mentioned earlier because I really feel that my muscles get loose. And the analogy that I heard from someone practicing somatics, which is a type of body therapy style, is that when you're doing like that rapid disruption on a muscle like that, is it that it disrupts the signal from the brain so it doesn't know if it's supposed to be tense or be relaxed, so it gets relaxed? Am I accurate there, or
that's a good question. I don't know exactly the mechanism of the machine, if it's directly
because it's just
on the muscle.
My experience, because it just gets relaxed.
Yeah, in fact, when we propose a conservative treatment, the patient asks me always what I should do first. I say, no, you have to do everything together. Because when you add together, you increase the chance to relax enough the muscles to reduce the pressure on the nerve. It's important to understand that the relaxation of the piriformis is just to reduce the pressure on the nerve, because the target is a nerve. But if you do just massage and nothing else, you will not correct the problem for the long term. If you stop to do the massage, the symptoms will be back. It's the reason why the key is really to treat the unbalanced bone pelvis, because it's probably the origin of the recurrent contraction of the muscle. It's the only hope to have a long-term efficiency is to correct this postural issue with really the origin of the contraction of the piriformis. When you do the Botox, when you do the massage, when you do the stretching, you relax the muscles. But if you don't correct the origin of the contraction, it will come back more or less faster, but it will come back for sure.
So interesting. And is there a question that I haven't asked that we should be talking about?
We have still a lot of things to explain, because we can enter more into detail about what the patients can hope or expect after the surgery. The question is why this surgery has so bad reputation. It's probably not due to the surgery itself. It's due to the lack of information provided to the patient. Why? After the surgery, the first week the patient has a banana, they say, no pain, I'm cured. And it's due to the effect of the general anesthesia, as I told you. It's not due to the surgery itself. After 1 week, the symptoms are coming back. And during the first month, it can become worse than before the surgery. It's very important to explain that in 50% of the case, the patient experienced its evolution with the transitory worsening of the symptoms. I have 3 patients who tried to commit a suicide during the first month. And you can imagine the intensity of the pain when the nerve is wake up. It can be the mess. I say always, if it's happened, it's a good news. because it means it's a sign of recovery of the nerve. But it concerns 50% of the patient. It's very important to explain that. Also, the recovery is really hopeless for the patients because it's up and down. After 1 month, you can wake up in the morning and say, super, I'm cured, and the day after, the symptoms are back. And it can change very quickly at the beginning. With the time, the frequency of the change is slower, and after 6 months, you can be 1 month good, followed with 1 month not so good. And it's important to explain that to the patient because it's easy. They accept always to be in a good month. It's more difficult for them to accept to have 1 month not so good. Of course, the intensity of the pain is also reducing with the time. And after 6 months, you have 1 month not so good, but not so intense that when you were just operate after the surgery. But it's information is very important to provide. Also, the delay is very long. The recovery of the nerve can be usually between 6 months and 2 years after the surgery, dependingly of many prognostic factors like the age of the patients, the intensity of the pain, the fact that you have pain during the night or not. If you have a positive block test of the pudendal nerve, it's a better prognostic factor. Then you have many things to explain to the patient. Also, I say always what I do after the surgery is a psychological support. It means that I just follow my patients and I explain to them, no, look, the illness is already better than 3 months ago. That is a sign of the recovery. Because you have also geographically a wave of recovery, usually coming from the anus and extended to the penis or to the clitoris. Because the nerve is coming from behind and the fibers who goes to the anus are shorter than the fibers who should go to the tip of the penis. And this is important to support them. Also, you have usually 3 phases. It's first numb. After it became hypersensitive and painful. It can be painful and when it became hypersensitive. And after you have a normal sensation which is coming back. Then this is the 3 steps with the wave of recovery extending from the anus in direction of the penis. It's important to explain that to the patients. The information is the most important before and after the surgery.
Yeah, so people know what to expect afterwards, so they don't
Exactly.
lose hope or think it's a failure of it, the
Exactly.
procedure. Yeah. Is there anything else you want to add that we haven't touched on?
We can discuss for a few hours more, but I think that the main message, the first thing is we have still hope. And that's very important for patients who suffer of this problem. We have still hope. And there are many people are too shy to go to the surgery. I say always, come on, it's 80% of success, then it's not, it's significant success rate. And if it doesn't work, you have 4 small skin incision on your belly, the risk is very small. You don't have surgery without risk, and that's always important. It's maybe a message that I should also give, is when we manipulate a nerve, we have always a risk to have some fibers inside the nerves who are injured during the surgery. It means that you can have, when you have a problem on the pudendal nerve, you can have a small part of the perineum who stay numb forever. It can be a small part around the anus, it's not a big issue, but it can be also a small part of the gland of the penis who can be a more problematic when you want to have sex. The zero risk surgery doesn't exist. I have just before a discussion with the patient who asked me, yeah, but I will be operated only if I'm sure that I will not have a worsening of the symptoms. I say I cannot promise that. They say statistically yes, but you have always the possibility of a problem. But finally, the life is a risk. When my patients are coming to my consultation using the car, they can die on the road. We take risk every day. The question is if the risk is reasonable or not. But the answer is in the hand of the patients. They have to decide what they want exactly.
Yeah, great point. Life is risk, even if we try to minimize it. And you know, in Sweden where I live, people are scared for pretty much everything, except when they have a couple of beers. And so if someone listening like feel that they have some of the symptoms we've been talking about and they want to get in contact with you, where do they go?
The easiest way is to contact the website Pudendal Surgery to have a video consultation with me. Is the easiest way for first contact.
That's
of
the first
course,
step.
if you prefer to take a flight, you can always take a flight to go to my consultation in Belgium, but it's a bit more time consuming and probably much more expensive.
Yeah. But see it as travel as well. You can see the world, and Belgium is a beautiful country, right?
Yeah, we have a lot of nice chocolates and beer.
Amazing, doctor. Thank you so much for your time. It's been really like eye-opening, and even doing the research, there was a lot of things that surprised me during our talk. And thank you for the work that you do and helping people get pain-free and live a better life. I'm always passionate about talking to people that are super niche into what they do. They have an expertise and they are helping people to improve their lives. So thank you for the work that you do.
You're welcome. It was a great pleasure for me.
Thank you.
Have a good day. Bye bye.